Our next speaker is Dr. Kenji Sunagawa. Again, Dr. Sunagawa has been one of the pioneers in hemodynamics from his time at Johns Hopkins. And since then, he's really been a pioneer in a different field, which is artificial control of neurocardiovascular systems, specifically with his, where he developed an artificial baroreflex system that controls cardiac contractility and cardiac oxygen consumption based on that. So Dr. Sunagawa is the director of cardiovascular medicine at Kyushu University. And thank you very much, Kenji, for coming.
Thank you very much, Chairman. And ladies and gentlemen, as he introduced me, I'm from Japan, and I was at Johns Hopkins years ago. I think it's late in 70s. So that's why I know Dan Barkov more than 35 years, nearly 40 years. So because of that, I think how he really assembled his talk, somewhat similar to what I'm going to show you. So, but don't disappoint us. So, the title of my talk is Neuromechanical Unloading. So this is acute, so unloading is a common phrase. And this slide illustrates what ischemia is. This kind of classical definition of ischemia and demand-supply relation. If the demand is more than supply, it causes ischemia. That, I think that kind of we can agree. So in the last 20 or 30 years, our treatment focused on supply, increasing in supply. So this is the place where intervention has been really exploded. But as Dr. Blomberg indicated that this increasing supply alone really can't improve the long-term prognosis. Then what happens if we can control, manipulate this demand? This is unloading in my definition. So if we could do it, it's kind of functional reperfusion. It's not physical, but we don't need much supply to keep myocardium alive. So it's kind of functional reperfusion. So I'm going to show you two techniques to keep myocardium alive while coronary perfusion flow remains limited. So this is the same slide that Dan used. Left side is pressure volume area, and it is proportional to the oxygen consumption, right-hand side. And Dan also indicated that the many factors could affect this relationship. But what I want to focus is this intercept of y-axis. Even if we can totally unload in terms of Dan's definition of full support and full unloading. So extreme case would be no PVA at all, but still we have enough oxygen consumption. So that is one critical point. The left panel indicates the pressure volume area under different conditions. Dan also indicated that if the unloading is partial, that increases cardiac output for sure. Cardiac output, in this case, combined output of left ventricle and the pump. Therefore, it increases arterial pressure. It is green line. Therefore, the afterload to the left ventricle increases. But at the same moment, preload to the left ventricle decreases when we unload the left ventricle. So right panel indicates the pressure volume area. So as long as the support is partial, we can't really reduce the oxygen consumption a lot. So this is kind of a framework. How it's really happened in the real world using impeller pump. So no support is no support. Partial support is partial, but you can see that pulsation is decreased in arterial system. Now total, and in this case, full support, I would say really full support. In this case, there is a big difference between arterial pressure and left ventricular pressure. The bottom, left bottom panel is pressure volume area, and the partial support will decrease preload, but increase in afterload. So the pressure actually gets higher. But you look at the red loop, that is in our definition of full support. So the middle panel indicates PVA. The PVA decreases as we increase the level of support. But the point I'd like to make clear is that even if we could reach full support, oxygen consumption decreases by maybe 50%, not more than that. That's the kind of the upper threshold we can achieve, but we can't decrease oxygen consumption of the heart more. That is impossible by this technique alone. What then we can add, or we can modify our technique of unloading, and that's a room for neuromodulation. There are many ways of modulating nerves, but in this case, I picked up vagal nerve stimulation. This is because that, as you know, that in patients with acute circulatory stress, like AMI, we know that patient is under sympathetic excitation. So this vagal activation, they antagonize sympathetic activation in many ways, and also it's very protective of ischemia. The left bottom panel, the blue indicate its chronic effect of vagal nerve stimulation on survival rate in animal model of chronic heart failure. So it improves survival a lot. As you know that there are several clinical studies, and the results are not quite really what I hoped, but still people are still exploring. But anyway, we use this technique in conjunction with mechanical unloading. So one of the limitations of stimulating a vagal nerve in animal or in patient is the kind of technique to stimulate vagal nerve. So we have been working on intravascular vagal nerve stimulation. In this case, this is animal study, and we are introducing the electrode through the superior vena cava and stimulating the vagal nerve. And you can see that it decreases heart rate. In this case, it decreases heart rate from 155 to maybe about 120. This could achieve very easily once you get used to. But so we capture the vagal system easily, intravascularly. Then Dan pointed out that heart rate is a critical element because the PVA, original concept of PVA describes simple work. But as he said, what we really concern is not the work, it's power. So it has to be normalized by unit time. So in this case, unit time is minute, then the heart rate plays major role. So what happened when we stimulate the vagal system? left panel indicated heart rate response. So heart rate dropped, in this case, 120 to 60 some. And we paced the heart as a control. Right panel indicate the myocardial oxygen consumption. In this case, we never touched actively the PVA by left ventricular assist device, but reduction of the heart rate alone reduced the MVO2 by almost 50%. But we paced, that is lost. We lost most of the reduction of the oxygen consumption. Now, what happened if we combined mechanical unloading and neural unloading? So left upper panel indicates just heart rate response. As long as we stimulate vagal system, it's dropped heart rate. The bottom panel is pressure volume area, and clearly, LVAD device decreases pressure volume area per beat. But in case of vagal nerve stimulation, it does not decrease PVA per beat. Actually, it often increase because the cardiac output is relatively maintained when we stimulate vagal system. Therefore, the stroke volume increases, and therefore, the PVA is relatively increased. So that's what's happening. But if you looked at the MVO2, the right panel, blue is without vagal stimulation. Depending upon the level of support, mechanical support, oxygen consumption decreases. But by adding vagal nerve stimulation, we can further decrease oxygen consumption for sure. So that's the effect of combination treatment on MVO2. What then translates this metabolic modulation by mechanical device and neural stimulation on what this impact is translated into the infarction size. So that's the experiment I'm going to show you. This is the experiment of combination treatment in dogs. There are 6 groups, no support of LVAD, partial support, total support, with vagal nerve stimulation and without vagal nerve stimulation. We created ischemia and reperfused after 3 hours. And we started vagal nerve stimulation or LVAD support or combination of them 1 hour after the onset of ischemia. So that's the kind of treatment during acute phase. Then evaluated the impact of that a month later. So it's a very simple protocol. Now this is the impact of treatment on cardiac function. Without vagal nerve stimulation, partial support or total support decreases EDP, improves endocystotic elastance, improves ejection fraction, and decreases NT-proBNP. What then happens when we add vagal nerve stimulation? As can be seen, it is obvious that it's further improve those cardiac parameters. What this improvement of cardiac function is translated into infarction size. This is a month later, we estimated infarction size by histology. And with partial LVAD, it decreases some, but not extremely. But with total or full support, reduction of infarction size is reaching something like 80%. Reduction is 80%. It's a huge reduction of infarction size. But what happens if we add vagal nerve stimulation? This is what we get. If you look at the first column of vagal nerve stimulation, this is without LVAD support. but infarction size is almost halved only by vagal nerve stimulation. Then partial BAD, total BAD with vagal nerve stimulation, it reduces infarction size more. The size of MI at combination treatment is something like 90% smaller than control infarction size. So it is really powerful intervention to reduce infarction size chronically. So what really causes this neuromodulation to the heart? That is not so clear, but we think that the heart rate reduction is the most important key. This illustrates effect Ivabradine on MVO2. Just like VNS, it has a similar effect. We are now working on a combination of treatment of pump and Ivabradine on infarction size, chronic size. So this is the last slide, and I think the combination of BAD and VNS is synergistic and reduce infarction size in the long term. But to make this really clinically available, we require the high flow pump. We depend on some companies like Aviomed. And also, how to optimize the combination remains to be seen, because there are a lot of combination. So we have to really optimize, and our end point is, I think, minimize the infarction size in the chronic phase. Thank you very much.
So we do have time for some questions.
So Kenji, if I can ask the first question. So, I mean, you and Dan show the relationship between PVA and MVO2 as a static sort of relationship, which in fact is the efficiency of the heart, right? And in ischemia or in heart failure, that relationship becomes worse. So, do you think that with the unloading, especially over a certain period of time, or with the neurohormonal or neuro stimulation, you're decreasing the slope of that relationship, along with moving up and down on that relationship?
I think you're really suggesting a good point. In our case, I showed you how the pump affects the MVO2, but the animals are under normal conditions. When we ligate coronary artery, we can't measure blood flow, therefore we can't measure oxygen consumption. That's the kind of limitation. However, what you said is totally true. It changes the basic relation between mechanical factor and oxygen consumption. So that is not included in this study. But I think we can guess a lot, but as the final point of extrapolation is how its impact on infarction size in chronic phase. That prediction still holds, even if we are knowing the PVA oxygen consumption relationship under physiologic conditions. So that is my immediate answer to your question. Yeah.
Thank you. Thank you, Dr. Sunagawa. You know there are devices for transcutaneous vagal stimulation that we placed on the ear. Do you know if they would have the same beneficial effects of vagal nerve stimulation that you see?
Well, my question is that we tried many ways of neuromodulations to control vagal nerve activities, but in case of this anti-ischemic, when we expect anti-ischemic effect, we really need to reduce heart rate, and this reduction must be larger than the other type of neuromodulation, such as neuromodulation in heart failure. In this case, we adjust the stimulation of vagal nerve system so that it does not change heart rate. That's the most of the protocols used in the clinical trials. So except for direct neurostimulation, I don't see really powerful way of reducing heart rate by vagal nerve stimulation. So that is my quick answer.
Very quickly, two last questions.
Yeah, very briefly, Kenji, that was a great talk. So I really like the term neuromechanical unloading. So do you think that the vagal nerve stimulation makes the pumps more efficient so that you can run these pumps at a lower RPM setting? You can have more durability of the pump or more efficacy from the pump by adding on top of just the pump itself neuromodulation?
Well, Naveen asked a really great point. As we know that the pump available now transvascularly really can't support adult cardiac output. So it has to be partial support. The partial support is not sufficient to reduce the infarction size. But if we combine that with vagal nerve stimulation, the effect reaches as much as the total support. So for a given moment, we can do only partial support. But if we can combine the vagal nerve stimulation or maybe blood cardiac agent like Ivabradine, I think the effect is close to total or full support. So I think we don't need to reduce support level, but even if we can do maximum, we can gain more by having extra neuromodulations. Thank you for your question.
Last question, please.
Thank you for your talk, Kenji. So these neuromodulation data are very interesting. Did you look on the periphery? Do you have any plans or any ideas on how this neuromodulation can affect the periphery and how these can get back to the heart and explain or expand some of the findings that you're seeing?
Well, that question is difficult to answer in short time. When I say neuromodulation, we are stimulating right vagal nerve. As you know, the 70% of vagal nerves are afferent nerve. So when we stimulate vagal nerve, it reaches cardiac sinus through efferent, but 70% are stimulating the brain. And there are major feedback in cardiovascular system through the brain. So the story is very complicated. So I really can't tell in short time how it's impact peripheral system, and that is very difficult to guess. So I think that is one of the reasons why we define the endpoint by infarction size alone. It's simple and I think very clear. Thank you.
Thank you very much.